Okay, I think we can begin. So thank you everyone for joining our session tonight, and thank you to those who have joined again from following on from last week. Welcome to the Rural Allied Health Interactive Student Webinar. Before we begin this session tonight, I would just like to acknowledge the traditional custodians on all the lands on which we are meeting on tonight and pay respect to elders past, present and emerging. So for those of you who don't know me, my name is Pip Kensett and I'm the program lead here at RDN in the Future Workforce team and a registered nurse by training. With me tonight, I have Chris Russell, the Future Workforce Manager at RDN, Joel from IT, making sure everything runs smoothly, and of course our very special guests, Gemma, Eleanor and Rach, who I will introduce to you a bit more sort of closely in a little bit. So welcome everyone, and thank you all so much for joining us this evening, and I hope you enjoy the session to come. Before we begin, I'd just like to go through a few housekeeping things. Firstly, tonight's session will be recorded, and that recording will be held on Rural Health Pro, which you guys will have all signed into tonight to join the session. If you have any tech issues at all, do not stress, simply close the browser, try and rejoin with the link, and if that doesn't work, feel free to email the student's email, which is the address you will have received your confirmation email from, and we'll make sure that we can fix that for you tonight. And lastly, as with last week, I just want to encourage you all to be, feel very welcome and excited to engage tonight. Last week we loved when you had your cameras on, you unmuted yourselves, and you engaged so well and asked questions and had some really interesting comments and concerns. So I'd encourage you all once again to participate as much as you can and feel very, very welcome and free to share your thoughts. This is a really supportive and safe space, and we're definitely not looking for any right or wrong answers. We just want to have a discussion about how the case studies, the rural context and your thinking may be shaped by what we go through. So please feel very welcome to do that. Okay, so Gemma, I think we can move on to the next slide. Okay. Okay, so I just wanted to take this moment to introduce to you Gemma Tucksworth. So Gemma is our special guest this evening. Now, Gemma is a physiotherapist with nearly 10 years of clinical experience in Perth, London, rural Western Australia, Tasmania, all over the place, including Papua New Guinea. She sort of left her clinical work and moved more into sort of leadership, management and planning, and has done incredible things in the wheat belt of Western Australia, Papua New Guinea, and in various parts of Tasmania and other areas, as you'll see in her bio. Gemma works for the Services for Australian Rural and Remote Allied Health, and we're really excited to be partnering with Sarah today in our Rural Health 20 conference, which I spoke to you all about last week and we'll touch on later, to make sure that our students know all about not only allied health opportunities in rural and remote areas, but also support and programs like the Rural Generalist. So I just want to welcome you, Gemma, and we'll just move to the next slide, and I'll welcome back our guests from last week. So Eleanor Knight, a speech pathologist from Royal Far West, and her colleague Rachel, who is an occupational therapist who you met last week, and we will be hearing from them and getting them really involved later when we go into our breakout groups and come back to the sort of group together and share our thoughts around that and hear their sort of opinions on some of the topics we're going to discuss tonight. So welcome back, Elle and Rach.
Thanks, Pip.
Okay, so without further ado, I'll hand over to Gemma and we'll get the session started. As I said, if you have any questions, please feel free to use the chat, or you can simply unmute yourself and ask at any time. But I'll pass over to you. Thanks so much, Gemma.
Thanks, Pip, for that lovely introduction. So I just wanted to get started tonight with a little discussion about what is a rural generalist. And it isn't at this stage in most of the or all of the allied health professions. It's not a specialty. You don't become a musculoskeletal or a specialist peds yet. We hope that that's where it goes in the future. But a rural generalist is an allied health clinician or a service that is positioned to respond to the broad range of healthcare needs that you find in a rural or remote community. So this is talking about clinical presentations and settings. So when we talk about clinical presentations, we're talking about all of those things that you would see from birth right up until death and palliative care, and in a variety of different settings. So you might be based in the hospital, you might be based in an outpatients clinic, you might do work in schools, farms, mines, under a tree. You know, like you can, your actual clinical setting as well as the type of care is very varied. And the primary aim of what we're trying to do with improving the rural generalist path, or improving the quality and the number of rural generalists, is to try and increase your preparedness or your readiness to face that huge spectrum of variety that you're going to see, which is actually a really exciting thing about being a generalist, because you get to see all sorts of different things every day. But on the very flip side of that coin is that can be very, very daunting, especially if you're a new grad. So how does somebody become a really, really good rural generalist practitioner? That's a conversation for a bit later. But for now, I have gone too far. I have still gone too far. There we go. Okay, apologies for that. So hopefully everybody can see the small writing on this timetable okay. And this is a little bit of an example of what your diary might look like if you're a rural generalist. So I'm a physio, so I've put physio down in the first column there, but I have had some OTs, speeches and dietitians give me some opinions about this as well, so it's not completely uninformed, but it is made up. There is no such place as Gemma's awesome aged care facility, although I think there possibly could be. So from a physio perspective, when I've worked rurally before, people that I know have kept the Monday morning free for sporting injuries, because, you know, footy, netball, hockey, big things in the country on the weekend. And if you don't have a private physiotherapist in town, or you don't have access to a private physiotherapist, or even if you are the private physiotherapist, keeping that time restricted on Monday mornings allows for those walk-ins to come in to get treated or educated on how to manage their injury. In this particular clinic, the guy actually has a relationship with an ARCHO, an Aboriginal Community Controlled Health Organisation, and he does a bit of telehealth because their community is pretty mad keen about football as well. And so he uses this space to do a bit of telehealth consultation for that. Going on, music and movement with the local music therapist in the nursing home, some outpatient type work, sort of very standard type when you think physio. Bit of workers' comp, had to go out to the farm and check out the farmer versus tractor situation. Pop back into the clinic to do a joint seating assessment with the OT, and then some telehealth follow-ups to round out the day. You'll also notice that this physio's got a grand final for netball coming up on the weekend, because it's really immersed in that whole community of living and working rurally. So I'll just give you 15 seconds just to have a look at the other disciplines for the moment. Is there any questions about that so far? No. So you can see we've got, when we think back to that definition of rural generalists, looking at this this calendar, we've got clinic work, school visits, multidisciplinary work, home visits, work visits, and of course the speech and dietitian are going on on some rural and remote outreach there too. The OT here is implementing a social farming program, which is, you know, been shown in some places in northern New South Wales and overseas to have great outcomes for functional ability and mood for farmers that have come off the land and ended up in aged care facilities. There's so much scope in the rural setting to be really innovative and to try and solve problems, which is another great point of the rural generalist. Lots of telehealth starting to pop up. If I'd given this lecture 6 months ago, or this talk 6 months ago, I'd be selling the benefits of telehealth, but I'm guessing that most of our audience tonight have used it now in some form or other. And the pictures here are just giving that idea. When we talked about the rural generalist definition, we've talked about the different types, birth to death, but we're also talking about different settings as well. So you might be based in a clinic, you might do outreach to various places. You might go by road, you might go by plane. I think this is up to Horn Island. And the bottom one, full disclosure, is me in PNG. So it's not actually Australia, but it is a remote clinic visit. So by boat. I don't think it would pass the Australian safety standards, but we get the idea. So thinking about this definition and this timetable, keeping those in the back of your head as we go into the case study. As you try and approach the case study, don't get too bogged down in the high-level specialist pointy end of your profession. Try to think more broadly from a patient perspective about patient goals, what they want, and what you can or might be able to bring to that scenario. So we'll move on across. So for our case study today, we have a 60-year-old Aboriginal grandmother who lives with her daughter and 4 grandchildren, 2 sets of cousins in there. She smokes 10 a day and denies alcohol use, and she helps look after the grandkids while her daughter's at work. She has past medical history of type 2 diabetes, hyperlipidemia, depression. Her medications are listed there. She has nil known allergies and a family history of same. So she presented to the COBAR multipurpose service 2 months ago with sudden onset weakness of the right leg and arm and slurred speech with increased confusion. She was reviewed and shipped out by flying doctors and to Dubbo Base Hospital, where they confirmed that she had an ischemic stroke. She was thrombolised and supportive care was commenced at the Dubbo Base Hospital. She commenced early rehabilitation with the relevant allied health professionals, including physio, OT, nutrition and speech. Given her type 2 diabetes, if there's any podiatrists on board, you could probably imagine she would have seen a pod as well. She most certainly would have seen a social worker. So if we've got any social workers on there, thinking about that as well. 4 weeks post-stroke, the patient was transferred back to COBAR for continued support and stroke rehabilitation. Patient self-discharged from COBAR because she was very anxious to return home with her family. Her niece, who's an Aboriginal health worker, has met you at the airport reporting that she's worried about her auntie's swallow, if you're a speechy. If you're a physio student or an OT student, I want you to think of something else like physio. It might be walking or transfers. Similar with OT, it might be self-care. If it's an OT, you might be thinking there might be some cognition. So I just want you to think about something related to your profession that Aboriginal health worker might meet your plane as you've come into your outreach clinic to say, Gemma, my auntie's real sick. Can you know, she's having a lot of trouble getting out of bed, or she can't get off the toilet, or she's coughing every time she swallows. So you're worried about her anti-swallow. This is the situation. What are the key assessment and intervention priorities? How would you work with the MDT? And what other factors might you consider? So I think we're going to move into our breakout rooms now to talk about these things. Oh,
Yep.
and sorry, before we do that, I just wanted to say that because you are an awesome speechy / OT physio podiatrist, you've looked at your calendar for the day in your outreach clinic, and you'll see in bright yellow there, you've managed to fit in a new assessment for this patient. And this is by juggling that around, because you're only in this outreach centre once a month or once a fortnight. You don't want to leave it until you're back again. And you happen to have worked very closely with the dietitian on this Happy Eaters feeding group for quite some time. And you guys have done some shared competencies, and you're quite happy that either of you could take lead on that group while the other one is doing something else. So with a little bit of juggling, you're going to squeeze in this assessment while your colleague helps cover that group. And now, breakout.
Okay, welcome back everyone. I hope you had a good time in your breakout rooms. I don't remember if they were numbered or letters. I got it all wrong last time, so I'm going to label them as Rach, Eleanor and Gemma. So I hope you had some good discussion. As I said, we're not marking anything. If you go off on a tangent, that's absolutely fine. Just want to see where your thinking goes, of course, with that rural generalist in mind, with the multidisciplinary in mind, and of course, rural as the key focus. I can see a few people turning on their cameras, which is great. The more faces we have, the better. It's really great to see you all, and it's more interactive. So let's start with Rach.
Does anyone from my group want to volunteer? We were very OT heavy, but we did have some nice pharmacy and med and physio input as well, if anyone in the group wants to put forward some of our ideas. Otherwise I can. So we had a big chat about, where possible, if you've got the time, getting a handover from hospital / rehab, and we had quite a chat about that double up, and several clinicians often having the same conversation with a patient, and how for a patient that's really, really frustrating thing. And so that's okay, Giselle. And so then if you have done that and gathered that information, how that can then support you in going out from, say, like an OT or physio point of view. If you need to take any extra equipment with you, you probably have an idea of what the home setup might be, what her mobility might be, and those sorts of things before you go. So if you do have to pack a bag of stuff for the plane, then you aren't taking the entire storeroom, you're only taking the bits and pieces that you need. And then from there, we just had a big chat around, when we were there with her, what we might do, have more functional assessment of ADLs and the home environment, and filling in gaps from if there was bits and pieces missing from hospital or rehab, so in terms of a COG assessment or anything like that. And we talked a lot about goals and meaningful goals, and how that will then work towards intervention as well, and really playing into looking at her roles at the moment. It's a very OT chat, but so in terms of being a grandmother and being a carer, and how she's come from an environment, Samantha raised this point, it was really great, how she's come from an environment of being cared for, and she's going back into an environment of being the carer, and how that could impact her recovery as well. And then how, as the clinician, you really want to work with her and the family. And a huge strength we talked about was having her niece, who is an Aboriginal health officer, and how fantastic that is as a really strong strength to support ongoing rehab at home. And then we talked about the potential of, because we've got that really strong family link, and how, you know, this lady might be a client who might not have been that exposed to the medical world prior to landing in hospital. And so the whole concept of telehealth may be quite huge. But then with the very strong strength of her niece being an AHO, how that could be beneficial to potentially exploring telehealth if, you know, COBAR is an area that you might only get to once a month or once every 6 weeks. So just those factors. Yeah, I might leave it there because I feel like everyone else will probably cover off lots of other awesome areas.
That's great. Thanks, Rach. We had a few crossovers there, but really good to see what you guys thought, probably more from an OT perspective. We talked a bit about, you know, generalist ideas there as well. So, okay, next up, Elle, if you're free, would your group like to go? Maybe you have a speaker or yourselves.
Yeah, so Kate has offered to chat through it. We had OT, speech and podiatry, which is pretty awesome. We cover a few different areas. And I think we had really great discussions. I was really impressed. But Kate has kindly volunteered.
Hi everyone. So we talked about doing assessments and things, and speech pathology. I'm afraid I don't know what these mean because of that. I'm not a speech pathologist, but we've got written an OMA, feeding trials, and an FCA, investigating language, aphasia, I don't know how to say that word, and voice, and all those kind of things that could be going wrong with speech. OT, we again talked about investigating roles, and while none of us have done cognition yet, obviously there's something there that you'd investigate, whether they're safe in their home and what they can and can't do. Range of motions and manual muscle testings, home community environmental assessments for equipment, and to just make sure that she's doing well in her home. And we highlighted not redoing the assessments, as you said, so that it's not exhausting and overlapping, and make sure that you're really working in that multidisciplinary sense. The podiatry said neuro assessment of lower limbs, vascular assessment of lower limbs, look at indoor versus outdoor shoes, and looking at any other chronic conditions, diabetes, do they need toenails, and falls assessments and things like that. Am I talking about the other side of things as well? That was our assessment for interventions.
Do you think Pip will go through the interventions? And I think the big part of it was knowing not to overlap, like, because with the FCA, that's a functional communication assessment that goes into cognition as well. So making sure you are communicating with the OT if they're going to be looking at cognition as well. Or, as you're saying, you know, talking to the OT beforehand, because you're the person that's going to be working with them. Like, you know, you can kind of touch on it, and whether there needs to be a more thorough investigation the next time the OT gets a chance. Then yeah, I think that, Kate, if you go on and talk through the kind of intervention ideas that we discussed.
Okay, so the speech pathologist had talked about working closely with a dietitian to make sure that everything's all in check. Compensatory strategies for rehabilitation, diet modification, postural modifications, and if they need any tools for eating. Looking at strengthening exercises for rehab, and the big one, that the big focus was education, empowerment and engagement. And OT was very similar, making sure that it's client-centred, you're involving the relevant people, and making sure that, being Aboriginal, that you're working with those health workers and working with the community and family and whoever they identify as needing to be there, making sure that that happens. Looking at mental health and really advocating for services, so making sure that you're not just saying you need this equipment, making sure that she knows how to get it and what funding and whatever else is out there to help her. And then we ran out of time. So, but I think empowerment and client-centred would be the big keywords out there.
That's clear. We were very much talking, I think, Kate, that was awesome. You summed up that so well, especially being a second year OT student. I think that's awesome. But yeah, very much talking about the functional side of things, how we're going to keep this family engaged and who are the key people, how we're going to, you know, motivate, empower, and you know, working with them, and yeah, client-centered. I think that was very important, especially in, you know, a rural setting and in Indigenous populations. It's a lot to kind of consider. It's not just something that you can go in wearing, fly in, fly out, disappear. It's very much a relationship-based situation, isn't it? Kind of working towards group therapies and whatnot in the future as well, to, you know, engage a lot of people and really work towards the next steps.
Fantastic. That's so good. And I think we also discussed that in both your groups have brought up this idea of relationships first and consulting the groups we have on the ground, whether that's in the MPS or the family or the Aboriginal health worker who's also family, and really utilising what we have on the ground, especially considering the barriers that you naturally face living in rural and remote locations. So great points. And thanks so much, Kate. That was a great synopsis. Okay, so I'll hand over to Gemma to start off, and to Josie, I think, was going to chat on behalf of our group, but Gemma, you can facilitate.
Thanks, Pip. We probably got distracted by my big picture thinking and looked less at the specific assessments and more at that kind of big picture approach in a rural area, like Pip said. Who's around? You know, what can you do? How do you access them? And just building on, I think, Kate, I think you said about the fatigue element and or asking the same questions. Everybody's asking the same questions. I'm not sure, you're rolling your eyes, Kate, so maybe it wasn't you that said that, so sorry. I'm not sure who it was. So that's a limitation, but also a strength. If you can get somebody on the phone or on telehealth while you are with the patient, a related discipline, to do a joint assessment with you while you're actually there. Thanks, Kate. Then you can do a joint assessment. These things are not beyond possibility with now that we have this awesome technology. But I'll hand over to Josie before I get carried away with the stuff again.
I think, like Gemma, what you were saying, we spoke about a little bit of assessment and intervention, but more so in that big picture and that multidisciplinary team or that team approach, and how that can really benefit. So one of the examples that we spoke about, which Gemma brought up, which I think is great, was, so I'm studying speech pathology, so if I went in there for a speech assessment and swallowing was quite functional, but it was more so the positioning of the patient or the client. So I needed to organise a chair, but there's no OT there, or there's no one else to sort of facilitate that. And so we're talking about how and what I could do in that situation, instead of just going, oh, well, you need to get a different chair, or you need to fix your posture and sit up straight while eating and then leave. We were then talking about how, okay, what can I do? I'm going to jump on the phone and I'm going to contact one of, the team members from back at the clinic and say, right, do you know of anyone in the area, or where can I grab this chair from, or where can I get this other support, or do you have any suggestions for the meantime until you can come and do your assessment, or this is what I'm seeing. And so we're talking more so around, just that communication within the team, and then also growing our own knowledge, I suppose, in the different disciplines, and just being the best support that we can do, because in a real, in the dream life situation, we'd have all of the disciplines there and being able to help that client, but in this scenario we don't. So I think we were talking about how we can just make the most of what we've got and the knowledge that we have, or just that team that we do have, that we may be able to access quickly on the phone, or like Gemma said before, doing that joint assessment. We might have them set up on the iPad, zooming in, so, or whatever that is. So that's kind of the focus that we had, which I thought was something really good to think about. Yeah, I think that was sort of the main thing, as well as we spoke about the importance of family too. So whether that is that support there and how beneficial they are, because if a health professional isn't able to visit our patient or client very often, educating the family and really building them up to support that person the best they can, which I think can quite often be very beneficial as well, and the families wanting to help. So we can really empower them by giving them some strategies and some things to implement too. So I think, looking at who's around that we can utilise.
That's great. Thanks, Josie. Anything to add, Gemma? No? Okay, so I think that's so good, and I'm so glad so many of you have engaged and brought all your ideas forward. I hope that there were, you know, lots of different discussions. Perhaps there's been some others rather than just OT, speech physio. If that's the case, feel free to put your ideas in the chat as well. Really great to hear what your sort of priorities were here and just your thinking. Gemma, I think we might go back to the slideshow. We're just going to discuss, and I know all of you were really excited by this last week, the distinction between multi, trans and interdisciplinary care. And I think it's really good to go through this clearly. And Eleanor, Rach and Gemma, if you want to sort of lead this and perhaps, you know, bring a real life example in, that'd be great. And then after that, we have another special guest from RDN, Cara, who is going to talk to us really briefly before we sign off about some sort of recruitment and sort of career opportunities that are available in rural areas for allied health, and just how all of this translates not just to how you deliver care, but what is an opportunity for you guys, and whether this is something you're interested in if you want to have a contact in the future. So Cara will have a quick hello and chat to you all before we sort of close, but I'll hand back over to you, Gemma. Thank you.
Okay, thanks, Pip. So there's quite a few different ways to consider multidis, interdis, trans, or multi-professional, interprofessional, trans-professional, integrated. There's lots of different words out there in the literature at the moment. At the bottom of this slide, sorry, the font is really small, but I can get Pip to send out the links. There's a research paper that compares a lot of the different models if you want more information, and there's also some stuff on our website around it. But you can think of it a little bit as a continuum of, and I'm going to use some wank words, of collaborative intensity. So how closely you are collaborating, or how intensely you are collaborating with your team, with the other disciplines or the other professionals in your team. So when you think about multidisciplinary, if any of you have done any placements in the hospital yet, you might have a ward meeting where you sit around and discuss a patient or discharge goals or that kind of thing. And that would be a multidisciplinary meeting. We've got lots of people that are coming together to talk about the care of the same patient, but a lot of those disciplines will do their care independently of one another. So each discipline's contributing their experiences independently. They might be doing it at the same time, like in parallel. They might be setting their own goals. So we spoke a little bit in our group about patient goals versus therapist goals. And their communication and their contributions are coordinated. So somebody is coordinating, pulling all of those things together. Each discipline could stand alone. So I could go and do my physio assessment, my mobility assessment of my new amputee. I could do that on my own. I could write a report, and I could send the report to my fellow colleagues who are involved, and they would read what I have done, and they would consider that as a multidisciplinary approach. Any questions about that one so far? No. Okay. So interdisciplinary, people are starting to come together a little bit more, and they're starting to, rather than being separate people standing separately at our 1.5 COVID meters in a room, we're actually starting to come together and be more shoulder to shoulder. We're starting to be more interactive and collaborative and more dependent on what each other are doing. And so great examples of this and I'm using a hospital example again, is, you know, you'll see joint assessments of stroke patients or post amputee, post-surgical patients between OTs and physios when they go in together. A lot of the subjective is similar. They help each other with the various components of that assessment. And Eleanor or Rachel, I might throw you guys on the spot and suggest that in your paediatric placement, there's probably quite a lot of interdisciplinary work you do together as well.
Yeah, and particularly from a setting and achieving goals point of view.
Yep.
And yeah, I think in a PED setting we see that a lot, and crossovers, you know, between speech and OT, often around engagement in play.
Yep.
And then you might see it, we say OT and psych around regulation and behaviour.
Yep.
Yeah.
And because a lot of, and even like OT and physio with that, like sort of all of the sensory stuff, the ability to sit still, and
OT and physio, even with mobility and transfers for kids as well, we see it a lot. Yeah. I know where Elle and I used to work in Wagga, we used to do a lot of joint OT physio work, particularly when we were doing a lot of prescripting of equipment too.
So in this interdisciplinary model, you're working very closely, you're working together, and you usually have shared goals, as Rachel said. And rather than your communication being coordinated, so somebody's pulling all the bits of the puzzle together, your communication is actually shared. You're working on the puzzle together at the same time.
And that might come across in your documentation, like your outcome documentation. So for reports or for bits and pieces like that, information for families, instead of, you know, speech, OT, it's all coming together as one piece to give, and showing how all the parts work together, as opposed to, you know, 4 different assessments from 4 different disciplines.
Yep. Thanks, Rach. And that leads very nicely into the last point on that slide, being that it's more than the sum of its parts. Another adult example, in a lot of falls clinics, you have a single falls assessment form, where one discipline will go through the initial assessment, which will include your subjective, and then it'll have something about continence, it'll have something about medication, it'll have something about mobility, it'll have something about functional assessment, it will have something about speech and intake. So the one person will be able to do that, and then funnel off referrals to the relevant allied health people. But the initial assessment is already done. So those people don't have to keep asking the same questions over and over again. So that's another example of how that looks practically. So the final, I guess at the other extreme end of the spectrum is the transdisciplinary model. Probably in the last 10 to 15 years, transdisciplinary has been a really scary word for a lot of places. They don't necessarily like necessarily liked transdisciplinary practice, because it throws up a lot of questions about scope of practice and that kind of thing. But more recently, allied health are getting much, much more clever at putting in governance structures around our transdisciplinary practice so that it is safe and it is appropriate. So what this means is that we're actually sharing knowledge and sharing skills and responsibilities. Sometimes this means working to our full scope that we get taught at uni. So say, for example, at university, as a physio, I got taught how to do a swallow assessment. Now, I couldn't do a swallow assessment today, no idea, but when I worked in the UK, I worked very, very closely with the speechy there, and so I was actually able to do swallow assessments in certain situations. I'm working to my full scope. I've already been taught how to do it. It's okay that I can do it, but somebody has just refreshed that information in my mind and checked that my skills are okay, signed off that my skills are okay, and I'm using that skill. In some cases, transdisciplinary can be beyond our scope, and we might call this skill sharing. And an example of this is when there's a program running in Queensland that I mentioned in our group before, where the podiatrist only visits the remote islands very, very rarely, but diabetes is a big problem. And so the podiatrist has taught the allied health team members how to do a high-risk foot assessment, so that when they come across somebody who is triggers some flags, they can do it and then feed back to the podiatrist for next steps and follow-up. Another,
sorry, Gemma, can I just add something in there about with the feeding assessments, and just saying that sometimes there are things that you might be put in a tricky place and you might feel like it is out of your scope, and not, you know, you want to stay within being safe, like you don't want to overstep that mark. So if you haven't had training and someone's expecting you to do something, you can say, I actually
absolutely,
maybe, you know, there are other options of filming the person eating and then being able to send that through to a speech pathologist, or, you know, having contact with your supervisor. You're not going to be thrown you know, there might be situations where you are thrown into a bit of a deep end, and if you do have the network, you do feel like you have, you know, you can kind of get through, but you don't want to be doing unsafe practices. You do want to be able, you won't have to do it if you don't feel confident, and there are people that you can kind of connect with. You will have a supervisor, you will be supported, you won't be completely
no. And thank you, Eleanor. That highlights the last point on under transdisciplinary, is it implies that there is cross training. So it implies that there is a governance structure that you're working under, that you've done your training with that skill, and it's context specific. So I worked in a transdisciplinary COPD team in Eastern London, and so I was trained to assess medications. I was trained to assess respiratory medications in community respiratory patients. I have no skill, and that was my competency that I was signed off on. I have no skills to be able to assess medication in any other situation. So I would not do that because it's beyond my scope. Similarly, at university, I was trained to do cervical manips and crack people's necks and those kinds of things. I haven't done that since university. That is beyond my scope. Even though as a physio, I can do it, it's not something that I'm competent and trained in at the moment. So what is in your scope depends on what you're practicing, what you're trained in, what you've got governance around. So what your managers or your support network or your peers have signed you off to be able to do. So there is boundary blurring. It is really exciting. It's exciting to be able to do stuff that is not traditionally your role, but because you are there and you have the training and you've got the competency to say so, it is exciting, but it's not something that you're going to be doing in your first week of graduating.
I think another part, it's the competency versus the confidence, because you can be completely confident coming out of your, you know, 4th year prac and feeling on top of the world. You've just passed, and you know, you feel like you know everything, and you know, you've had really good feedback from your supervisor, but it's very different. So I think it's really important just to kind of check confidence and make sure that you have the competence to match it.
Excellent. Yep. So that's the spectrum. Well, and I guess the thing that's missing off the spectrum is, you know, your solo person who's not working in a team at all at one end, through to your transdisciplinary where you're working within a team. And the transdisciplinary doesn't imply that you are the only person doing everything. You are still working within a team. You still have a frame of reference to come back to when you are working in those blurred areas. But when we talk about that sort of collaborative intensity, that's the spectrum across. And I'm checking I haven't missed anything. Okay, can anybody, does anybody want to throw at us some examples of an interdisciplinary or transdisciplinary work that you may have come across in your readings or your placements or anything like that?
I'm just thinking about an example. I'm thinking perhaps maybe for transdisciplinary is on my 2nd year placement, I was working in PEDS, and we had a little boy who was so restless. He couldn't really sit down for much therapy, and it was so hard to just, you know, keep him still. And so we were looking at maybe like a bit of a sensory demand, and so we implemented a vibrating cushion. And so whilst that's not something that specifically like I learnt at uni or technically is like maybe a speech role, but my clinical educator had perhaps that cross training for that sensory like intervention. So I'm thinking that might be a transdisciplinary example, but yeah.
Yeah, I mean, it's probably closer to interdisciplinary just because of the, it's one of those things that probably comes from working together in those situations frequently and often, that you start to pick up those little bits and pieces, and there's not necessarily the need for a governance around it. But Eleanor and Rachel might, I don't know what you think. You guys are the PEDS experts.
No, I think you're right in that, Gemma. I think where you might see it in terms of a clinical setting would be often if you're in a practice, if you guys have an early intervention placement, a lot of EI settings, particularly in Victoria under Noah's Ark, are a transdisciplinary key worker model style practice. That's where you tend to see it quite a bit more in terms of the model and how everything kind of pans out for a client from when they first come in to when they finish with you. But yeah, that's definitely a setting there. And that follows along that more line that Gemma was talking about before, where you have one person that could be from any discipline that does that first interview with the family and kind of may do as much as they can within their scope to support that family to progressing towards their main priorities or goals, and then bring in, once you're kind of pushing scope a bit hard, then they might bring in other clinicians to support. And a lot of that is to support resourcing and that sort of stuff as well. I think, Pip, did you want to pop something in here?
Yeah, so I think this is really good. I'm so glad everyone's getting, thinking of their own examples and doing all that. We might have to wriggle on a bit, but I was thinking, Gemma, that we could perhaps, if there's interest from this, we could look to, continue the conversation on Rural Health Pro, on the digital platform that we have. I'm sure Gemma's very happy to come back and we can talk through that platform, or else, arrange that we can share our emails or whatever. But if it's okay, we might now move on to Cara. I'll let her introduce herself.
Thanks, Pip. I'll be really, really quick. I promise. It's nearly 8 o'clock on a Tuesday night, so I bet you're all ready to switch off and probably go and have some dinner. My name's Cara Brogan. So here at RDN, I look after the nursing and allied health recruitment within our workforce team. So I know that a lot of you online tonight are at all different stages of your professional careers as students and as clinicians. But basically, I just wanted to start the conversation tonight and introduce an opportunity, or multiple opportunities that you may not be aware of. So as well as running some fantastic events and hosting nights such as these, RDN also offers a range of other workforce support services, and one of those is recruitment and retention services. So we actually support practices and organisations as well as individual health professionals with recruitment assistance and workforce grants. So this means that we provide free advertising services for practices and organisations, and when we do find suitable candidates, they don't have to pay any placement fees or anything like that. It's all basically just to support that rural health workforce. For individual clinicians, we provide pretty much everything from CV preparation tips to advice regarding, registration pathways for international graduates. Basically, the world is your oyster and we want to help you get the most out of your careers. And I think that especially this stage, moving forward into the workforce as new graduates, is a really special time. And I think it's really instrumental in planning your future. So we want to be able to do everything that we can for you to get the best opportunity possible. We're currently advertising for a bunch of new roles that are applicable for new graduates. So I'll share my email with you all in the chat box. very soon when I figure out how to do that. But also, oh, there we go. Also, I just wanted to let you know that we have things like workforce grants. So we also provide funding to go towards things like site visits, relocation grants. So if you're interested in working rurally, basically we want to be able to do everything we can to help you get there. So as well as these grants, we provide retention services. We've got a dedicated retention team that will touch base with you and help you transition into a new community and into a new workforce. And then you may or may not have heard of our Health Workforce Scholarships program. This is another workforce program that's aimed at further upskilling and additional study for rural clinicians. So as I said before, the world is your oyster. I know that in the last financial year, we supported over 1,400 allied health providers with bursary payments to go towards their upskilling, which is massive. And it's something that I know that the team's really proud of. So as I said, we want to be able to help you when we can. So please don't hesitate to get in touch. I've included my email in the chat and I hope to hear from you all very soon. Thanks, Pip.
Thanks, Cara. And if any of you need that email or anything else, just let me know and I'll make sure you get that. Okay, so I know everyone has to rush off and have their dinner, but I just want to share with you that we do have a survey. We'd love to have your feedback, and we always want to try and improve these sessions, find out what students and allied health professionals are looking for. So if you have 5 minutes, please just fill out that survey now. It's in the chat. And of course, I want to thank you all for joining us. Of course, our special guests, Rach, Elle and Gemma, on behalf of Sarah, thank you very much for joining us, and thanks Gemma for working with us and having Sarah be part of RDN here and making this happen for our students. I also want to remind you all that we can continue this conversation on Rural Health Pro, and as I said, you signed up through this, please do go on. I'm around if you want to have a chat on that. Otherwise, share any cool videos, articles, ideas, anything you have, and we'll get that group really going. So, and I also want to thank Joel from IT. Thank you very much for being around. And of course, to all of you for participating and making this session so much fun. So thank you. If you have any last minute questions, feel free to just have a chat now. Otherwise, it's okay if you all go, and thanks for joining.